Hi, welcome to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert Yip. We're second year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised, Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or supervisors. Welcome back.
Yes, and it's been a couple weeks since we last saw each other because we finished our final exams. We've been on break since.
Congratulations, by the way.
You too.
How did you find our final exam period?
I think it was okay because, this is not our first rodeo, and, we're getting used to the workload and the pacing of medical school. And second year, I think in general, as we mentioned in previous podcasts, previous episodes, there's a lot of other things to look forward to or focus on besides just studying. So the exams themselves, I didn't think it was that bad.
Yeah, same. And I actually had a bit of fun with them. Like, I always personally really enjoy our anatomy exams. Like, for our anatomy exams, they bring us down into the cadaver lab which has all the bodies that we've been working on throughout the semester.
Mm-hmm.
And it's like a bell ringer exam, so you have a minute to answer a question that's related to the cadaver that you're seeing, and then you have to move to the next station, and so on. But it's actually, I really enjoy it because the dissections are done nicely for once, and like throughout the semester, it's good practice to do these dissections, but you end up not getting quite a good view of what you're seeing because of just a lack of skill of the students. Mm-hmm. And so actually to move around all the stations and actually be able to see all the anatomy and all the different cadavers, all the different bodies, I always really enjoy during the exams. And I'm usually not too stressed out that I can appreciate that while I'm going through.
Yeah. And also this time we had, for the very first time, for us at least, a histology bell ringer kind of. I know in other schools they will do it differently where they have actual microscope slides and you have to actually find and describe it at the microscope. But here we had the images projected onto a big screen, and it would just switch the slide. And beforehand, we would just have our histo questions as just regular MCQs. So this was, I think, kind of interesting, and it was nice because it was all consolidated into one session.
Yeah, and what's the best? What I like about the bell ringer kind of style is that once that minute is up and it goes to the next question, like, you have to just put something down and move on and forget about it. You don't have any time. You don't have any time to to constantly think over your answer, change it 20 times, and then,
Yeah,
as you would like in a multiple choice. So I like that. But I can't believe it. We are no. So just gonna say we're halfway through second year, and all the way next summer, early summer, we're going to be doing our clerkship. It's just flying. It's just flying by.
Yes, and I know you will be staying in Vancouver, but I'm also luckily staying in Vancouver with the first round of matches, which was
good.
Nice. Yes.
Yeah, so I guess it's a bit of a lottery system this year, but we both get to stay more local. That's excellent.
Mm-hmm. There is also, more rural sites, and I understand that if you're placed more rurally, there are advantages to that, right? Like, you get to know your patients better and community better, and you get to do more because there's less people and less support. But on the other hand, there are more opportunities to do or observe or participate in more specialized services when you're in Vancouver, right?
Yes, and I think that's the trade-off. I know a number of our colleagues that I've talked to have expressed greater interest in going rural because of just this fact that they'll be able to, their scope of what they're going to be doing is larger. If you, depending on how rural you go, you might be having to assist with surgery, whatever it is, doing. The list is endless. But when they don't have as many hands, the medical student or the clerk ends up with greater responsibilities. And I can see that's very desirable just for your learning.
Yeah, it'll prepare you very well for the future, of course, and also if you do want to do something like anesthesiology, something procedural, I think it would be very helpful to have that kind of training early on.
Yeah, I think so. Something we will not get staying in the big urban center.
Oh,
But
who
speaking
knows?
of, who knows? It's true. Speaking of clerkship, though, of course, it's just one step towards residency. And
Hmm.
I was thinking about these poor residents after you sent me a newer publication in JAMA recently that looked at food insecurity
Mm.
among residents. And I think it's just American medical residents. Is that correct?
Yep, that's right.
Maybe you could refresh me and kind of share with our listeners, the general overview and the findings of that study because it's quite interesting and depressing.
Yeah, it's concerning for sure. It's a cross-sectional study. They involved 4 sites in the US. 3 were considered metropolitan, so something like Vancouver with more than 1 million residents. And then one of those sites was a smaller suburban center with less than 250,000 people. Overall, they talked to over 3,000 residents and physician fellows, and they looked at not only food insecurity, but also burnout, the intent to stay at their home institution after training, and then the feelings of social isolation. So that was the overall design of the study. In terms of the breakdown of the demographics, we mentioned training sites. So only we'll talk about the food insecurity within those training sites a little later, but um, they had a good diversity of ethnicities. So Asian, Black, or African American, white, Hispanic, etc. And then they also looked at differences between postgraduate years, so years of training. Um, so in terms of the results, overall in the total study population, the prevalence of food insecurity was 13.7%. That's roughly 1 in 7. That's really high, I think.
And did I believe also whether the residents were food insecure or not correlated with the other outcomes as well.
Yes. So it correlated with burnout. It correlated with decreased intent to stay at the home institution, and then also increased social isolation, which you can expect, right? In terms of the demographics, there was less, interestingly, less food insecurity at the smaller site. So only 4.5% versus the other larger sites over 15%. The highest percentage was 21.3%. And this is almost kind of surprising, right? Because you'd think at a big urban center, you'd have more support, more resources to help your um, trainees, but it was the opposite. So it's kind of interesting. Um,
It's very interesting, and of course, this is some kind of signal there, but we have to remember the nature of the study. It's questionnaire based. I think
mhm.
one must ask, okay, how do you define being food insecure or not? And I believe they use a validated tool.
Yep.
It's basically just a two question screening tool, I believe. And I thought I had the questions up here, but now I can't find them, but they're essentially, have you experienced, like, any time in the last 6 months, have you ever thought to yourself, or have you ever worried that you wouldn't have money to buy food the next week, or these kind of questions, like very general questions about food insecurity. I think there's just two screening questions, and that either qualifies you as a yes or a no in terms of being food insecure. So very concerning. Obviously, it's a lower quality in terms of the results, but still interesting nonetheless. And I'm wondering how this happens. These are individuals who are embarking on a great career. Physicians, especially in America, there's no shortage of. I mean, they have very high salaries. It's different for the residents, of course, and we go through this in Canada as well, where they kind of, um, it's at least thought that the system kind of works the residents quite hard because they don't have to pay the residents very much, and so it's almost like cheap labor. I don't know how fair of a characterization that is, but you wouldn't expect residents to still be so you wouldn't expect residents to be so short on money that they're having trouble affording food.
Mhm. And it's interesting to note that all of these programs that these trainees were in had food allowances. So these are programs that either they have the ability to spend money on food within the hospital at a subsidized price, or they have some extra money that they're given specifically to spend on food wherever they choose. So despite that, it's just not sufficient for 1 in 7.
Hmm. It's fascinating. I'm wondering if the results of this study will lead to any kind of policy changes, or if it would just kind of be an interesting fact to know.
Yeah, who
But I
knows?
guess only time will tell. That's very interesting. Well, in other news, we, as promised from last episode, have our first guest to ever appear on Two Guys in Scrubs,
Mm-hmm.
and we're absolutely delighted to have him with us. So, who we're going to speak with today is Dr. Gidon Frame. Dr. Gidon Frame is a physician currently practicing in Vancouver, British Columbia, where we're living. He completed medical school at Wits University in Johannesburg and completed his internship in Soweto at the largest hospital in the Southern Hemisphere, which is also in South Africa. He moved to Canada in 1990, where he initially practiced family medicine in northern Manitoba. In 1993, he opened a family practice clinic in Burnaby, BC, and he's been serving the community since then. He completed Canadian Family Practice certification and later became a fellow of the College of Family Practitioners. His interest in preventative health led him to gradually transition to anti-aging, regenerative, and aesthetic medicine, which he's now been practicing for 23 years. He's a certified menopause practitioner with the Menopause Society. He's certified with the American Board of Anti-Aging and Regenerative Medicine, and he's a clinical associate professor with the University of British Columbia. As one of the early adopters of aesthetic medicine, he's become a key opinion leader and instructor of non-surgical cosmetic procedures, speaking and instructing internationally. He currently runs one of the most successful anti-aging and aesthetic medicine clinics in BC, and he's a leading voice in the field. So without any further ado, please welcome Dr. Gidon Frame.
Great. So we have Dr. Gidon Frame, and Silas read out his biography to us just now. Gidon, I hope. Oh, Dr. Frame, is it okay if we call you Dr. Frame, or do you prefer?
I prefer Gidon, if you can
Gidon?
pronounce it.
Okay. Am I doing it okay?
Yeah, you're doing it great.
Thank you. Okay, so Gidon, our first question for you is about private healthcare, because in BC, this refers to any healthcare service that isn't billable under MSP. And I wanted you to describe the types of services that you currently offer or are exploring that fall outside MSP funded healthcare.
Private healthcare is it's kind of a misnomer because private and personalized crossover. But in the BC context, I think what we mean with private means pay cash out of pocket. That's what it's tended to be referred to. And it ranges from everything such as naturopathic care, physiotherapy, allied health practitioners, and then even medical practitioners, and I mean registered medical practitioners, doing a multitude of things. There are even some that are charging to join their club. For example, you have a block fee. If you say I'm a family practitioner in Sassamat, and I'll tell somebody, okay, if you want to be my family practitioner, you've got to pay me $2,000 a year. You can join my club, and then I'll provide MSP, public healthcare funded services for you. That falls under the gamut of private care. Now, the law is quite firm, but yet quite vague. So anything the Canada Health Act, which means necessary medical care, can officially be charged. And anything that is covered by the Canada Health Care Act, you cannot charge for. So it seems that it's quite clear, but there's a huge, huge gray zone. And those of us in the private healthcare sphere have to navigate this almost every day and watch our backs because we don't want to be found to be illegal, such as, unfortunately, one of our colleagues, Dr. Brian Day, was offering private expedited knee surgery and orthopedic surgery. And he was found to be, unfortunately, liable under the law and was not able to continue with his services. So we're all watching our backs intensely. But in the end, we're trying to provide the best possible care for our patients. That's essentially what we're trying to do.
Mm.
And what kind of services do you provide currently, and has it changed in the decades that you've been in this space? And I guess so. What is your version of the gray area?
We have, we started, well, let's go back. Let's rewind a little bit. We started in the area of what was called euphemistically anti-aging medicine. Now, of course, it doesn't exist. There's no way to anti-age a human being at this stage. Your lifespan is pretty fixed. John de Comet lived to 128. I don't think we can get anybody to 150 and 200. That would be true anti-aging. Like we can do with rats. Rats, worms, flies, we can anti-age them. We can give them rapamycin or some other kind of concoction. We can make them live 20, 30, 40% longer. Can't do that to humans because there's no such, well, there's no proof of such. So we started with this anti-aging medicine, which was a bit of a pipe dream, and it started 25 or so years ago. We got into it about 23 years ago, and we were really just trying to improve quality of life. That was what it boiled down to. So, and we could, because I typically spent 1 to 2 hours with my patients, sitting down individually and doing a private preventative healthcare review. That wasn't covered, so we could charge privately for such. And I was still doing family practice at the time, doing our 5 to 8 minute consultations and trying to do a decent job in that sphere as well. So that's how it began with hormone therapy, menopause management, andropause, testosterone, and then it slowly morphed. And now, today, it's the whole range of anything that somebody wants to sit down and discuss about their own personal healthcare needs. And most of it is what we now call personalized medicine or private personalized medicine. So, for example, you can go to your GP once a year and say, if you're of a certain age, and say, I'd like a review. And your GP will obviously be able to provide good care and say, okay, let's do a colonoscopy if you need it. Let's do a mammogram if you qualify. Let's check your cholesterol, check for diabetes. That's pretty much what you get, based on screening guidelines. Those are the things that we are told adults in BC should be screened for. But if you want to go a bit further and you have some risk in your family and you want to dive into it, try bringing that up with your GP. Say, I've got this family history of some cancers. And they'll say, okay, um, make another appointment. That's another issue. Come back and see me. And most of us don't do that. We don't go back. We don't
Mhm.
go and delve into it personally and privately. Otherwise, I sometimes tell my patients, okay, you've got a GP. You're lucky to have one because a fair proportion of British Columbians don't. And if you want to deal with all these issues and you keep being told one issue per visit, no, you have to come back. Well, book 6 visits once a week, every Tuesday at 11 o'clock in the morning. You pitch at your GP's office. You say, okay, I'm dealing with item number 17 now. And you might get good healthcare, but it's pretty fragmented, unfortunately. But if you want to do that all at once and you want to come in for a 1 to 2 hour visit, um, then that's what we charge privately for.
So one criticism of this system is that people who can't afford it are being sort of um, gated out of this whole array of services and providers, and they call it a two-tiered system. Um, from your perspective, practicing in both systems, do you think that this concern is justified?
Well, the concern is justified, but hey, kiddo, it's real. This is the world. The whole
Hmm.
world is a two-tier system. In fact, it's a five-tier system. I grew up in South Africa, and my early practice in general medicine and family practice was in South Africa. And you learned, and this was under apartheid, where it was segregated not just economically, but racially. You had a black system, which was the public system only, which was excellent doctors trying to do missionary type work with terrible circumstances. And then you had the white hospitals, and these could be even poor white patients coming there, getting incredible care, academic medicine with professors walking around all the resources. I mean, we had a shocking cutoff, and this was clear two-tier system at its best. If you were born and you were under 1 kilogram, you didn't get a chance to live. The nurses used the midwives in our maternity ward in Baragwanath Hospital, which was the biggest hospital in South Africa and probably the biggest in Southern Hemisphere, over 3,000 beds. They used to weigh the newborns, and if they didn't make a kilo, they were under a kilo, they were left in the utility room to essentially die. Because more than under a kilo, they were going to block an ICU bed for too long, which would then deprive tens or hundreds of other kids from being saved. So we already had an incredible diversity of care, and this happens all over the world. We're just, we're in La La Land here in British Columbia. Unfortunately, we think everybody gets MSP type care all over the world, and if you don't get what is available to you publicly here, well, you must be deprived. The reality is most of the world is deprived of adequate health care. Yeah, they got vaccination, and it's gone a lot better in the last 30, 40 years. But they don't get what we get in British Columbia. There's no question about it. We are absolutely privileged here. In South Africa, we drew up a commission to push for a national health system because there was none at the time. And we dreamed of having a healthcare like we have here in Canada. So we've got it good. We've got gaps. There's mediocre care in many places. There's long wait lists. But our markers of health are pretty good in Canada. So we've got a baseline of excellent care. And if you want better than that and you can afford that, well, you should be able to pay for it. And we can be holier than thou. And, we do it here in Canada. We say, oh, no, 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 we can't let people pay for private CTs or private orthopedic surgery because it'll deprive the national health system, the Medicare system of funding. That's one of the criticisms of private care. Reality is the rich have always been able to go wherever they want. My patients fly to Dubai for latest treatment. They go to Germany for leg elongation treatment. They go down to the States and they pay for. They go to Mexico and they pay for orthopedic surgery. It's the harsh reality of the world that two-tier and three and four-tier systems exist. So let's make the best of it. Let's make sure the public system is great, and let's make sure that private care is also available for those that want to push it a little bit further.
Fascinating. So when it comes to the patients that you do see privately, how do you help these patients understand the distinction between the care that's not deemed medically necessary versus care that may be clinically beneficial to them, but simply not covered by MSP? Or does this conversation ever come up? Do the patients ask questions in this area?
Yeah, we face that all the time. There's no good answer, unfortunately, because there's a huge gray zone. I sometimes sit with people. I'll take a typical patient, a 54-year-old male. He's got a little bit of a family history of some heart disease, but it doesn't quite meet the criteria of premature coronary artery disease under the age of 55 for a male. He's got a little bit of risk factors, used to smoke, and has already had a cholesterol test, has had fasting blood sugar, HbA1c, has had diabetes testing, and has been told, okay, exercise, go out, eat well, exercise. And they want more than that. So I'll say to them, okay, there is a test that is available called a CT coronary artery calcium score. It's $750 in Canada. You can probably get it for 300 in Bellingham or 150 in Thailand. But in Canada at the moment, in BC, the price is $750. You can go and get that test tomorrow if you want. I'll order it privately. If you want to try and get it on the medical plan, I can put in a requisition. I'll put your risk factors down and let's see. You might wait 6 months, a year. You might not get the test because some algorithm might say you don't warrant it. Worse still, I can send you to a cardiologist, might be unnecessary, and you can wait and see if they decide that you warrant this test. So the choice is there. It's available. And most people will, for the cost of two tires on your car, will probably go and get the CT coronary artery calcium score if they're really motivated. And we have discovered a huge amount of hidden coronary artery disease that doesn't meet the criteria for a stent or a bypass,
Mm.
but certainly meets the criteria for more aggressive risk factor management and has made the difference of should you be on a statin for cholesterol lowering or should you not? And you only know this if you go and look for it. So there is a good argument that people over 50 in BC should all be getting a CT coronary artery calcium score. But it's unfortunately not feasible because, I mean, do the math. $750 a person. We've got about 1 million people in BC. Oh, maybe 2 million people over the age of 50. So do the math. That's about 1.5 billion. We don't have the money in BC to do that. So everybody gets your standard care, which is good, better than most parts of the world. And those that are motivated and do want to spend the extra money will go ahead and avail themselves of tests like that, like a total body MRI or a CT coronary angiogram. There's a whole range, and I don't tell everybody to do everything. It's a waste of time and waste of money, and you're going to find a whole bunch of red herrings. But after we spent an hour talking about your risks, we get a better idea of which tests you may want to spend your money on and where they might help you and where they might change management in your case. It's not for everybody, I can assure you. I'm not advocating for the government to spend billions and billions on intensive genetic imaging and blood tests on every single person. It's just not worthwhile. But
Mm.
personalized medicine means individualizing the risk, working out where you have risk factors, and deciding which way to go and where to spend your money.
Mhm. So, you mentioned CT coronary angiography. I'm curious if there are other specific services or tests that you often recommend or are only offered privately that you think that the public system might benefit from adopting.
Yep, there's a few. There's in the field of cancer detection, early cancer detection. There are a number of tests that are now available that are being studied actually in the NHS in England. They're just adopting a huge big trial for a cell-free DNA, otherwise known as liquid
Mm.
biopsy. There's a company called Gallery, and this test is incredibly useful. It takes one vial of blood, looks for little fragments of mutated DNA. Most cancers, when they get going, when they're still in the few cells in the organ stage, they start mutating the DNA, and little pieces of DNA leak out into the bloodstream. Those are called cell-free DNA. It's not the cancer spreading around, it's just little fragments of DNA. You can do a blood test that can detect some of those fragments. And the Gallery test picks up fragments from 50 different types of cancer. Now, in the public system, you'd have to look at what's the yield? How many cancers are we going to find? How many of them are treatable? How many lives are we going to save for how much money is going to be spent? And if you do the math, it may not be worthwhile. It's a couple of billion to do all people over 50. But if you've got a strong family history of cancer, of premature cancers in your family, you may well want to spend the 950 US dollars to get this test. It's not available in Canada, unfortunately. There's an outfit in Toronto that are trying to offer a similar test, but it's actually double the price. So I advise my patients, if you want to do this test, spend the 950 US dollars, which is probably what, about 1400 Canadian these days, and do the test. And over the age of 50, you've got a 1% chance that this test is going to come back positive. And of those 1%, half of them are going to be true cancers. So half are going to have a red herring, maybe cause unnecessary investigation, maybe give you a lot of anxiety. But a 0.5% of the people over 50 doing the test are going to find out that they have an early form of cancer that may be much more treatable than waiting for it to turn into a huge tumor or even metastasize. So that's a great one. I would say the cell-free DNA is a low-hanging fruit for anyone who can afford that and is of risk. There's another great test. It's in the genomics field known as pharmacogenomics. This is how we metabolize drugs. There is uh, there are the cytochrome P450 systems in your liver. These are your enzymes that metabolize various drugs. And like some people, they just have a bad reaction to certain drugs. You give them a blood pressure pill, a certain ACE inhibitor, and they just don't react well to it. They feel terrible. It doesn't drop the blood pressure properly. They get the side effects more. And we don't we don't really know why some people, in the medical field, we call them whiners. These guys, everything I give them, they're getting the headache. They read the side effect profile in the monograph and they've got all of them. Well, you know what? They may not be faking it, or they may not be exaggerating or over amplifying. They may actually have a genetically determined poor ability to metabolize that particular drug. So I advise my patients who've had a hard time finding the right SSRI for their depression. Uh, they have difficulty with certain antibiotics. They have difficulty with certain cholesterol lowering medications. Send off your saliva to one of the outfits. There's a few of them that do it in BC and in Canada, and we will actually be able to see which systems you metabolize normally and which you're a slow metabolizer and which you're a rapid metabolizer. We can then take any drug, we know which cytochrome system it goes through, and plug it in and see, is this drug a good match for you? In the future, it's going to be baked in. We're all going to have pharmacogenomics. It's going to be in your health records. And anytime a physician prescribes a drug, it'll immediately, the AI will match it to your cytochrome system and we'll see whether this is a good choice of drug or not. So I think, I advise this for anybody who's had difficulty metabolizing medication.
That sounds great. And it's not only just the like minor side effects like headache or
They can be deadly.
malaise. Exactly, like SJS, TEN. Yeah.
Yeah. You can have deadly side effects. You can get clashes between medication that you didn't know about. For example, you can get a prolonged, what you mentioned, the prolonged QT syndromes. If you're oversensitive or you build up too many metabolites, and for example, your atorvastatin is going to clash with your clarithromycin, with your azithromycin, and you're more at risk of getting prolonged QT, or you can get serotonin syndrome with certain combinations of drugs more likely. So it's more important, I agree, to have the right amount of drugs and at a decent cost for the right amount of people. But this is next level personalized medicine, and it's not currently available on the healthcare. So if you want to do it, go ahead, pay for it and do it. It's not cheap, but it ranges from $300 to $500 depending on the provider. But it's an incredible service. I really do think so. I think that's the future of personalized medicine, is going to be all the genomics, because more and more is coming down the pipeline.
It's absolutely fascinating.
Yeah.
Just as we have just a few more minutes with you here, Gidon, I'd like to transition just at the end and maybe ask you a few questions, because outside of your work in private care, as you were describing, you also do aesthetic medicine, and you're very well regarded in the field as being one of the earliest adopters, at least in this part of the world, of non-surgical aesthetic procedures and so on. So my question, I kind of have a two-part question. Critics of aesthetic medicine may kind of criticize this term itself, even being a bit of an oxymoron. If we're doing aesthetics, how can this be medicine? And they see this dichotomy there. So maybe the part A of the question is, in what ways can the term aesthetic medicine be justified, and maybe what are the ways that it might be closer to a standard medical procedure than the average person might perceive it? And then part B, if we were to accept aesthetics as being medical in the same way we think of chemotherapy, or for example, then does this all of a sudden pathologize people's different phenotypes, variation? Maybe if someone's born with a facial feature they don't like, then now it becomes a medical problem. So you can kind of take that question any direction you like.
This is the rub. Aesthetic medicine. Yeah, I had the same dilemma about 22, 23 years ago. It was suggested that aesthetic medicine was now becoming part of anti-aging medicine, and at all the conferences, there was starting to be aesthetic medicine vendors and laser machines, and botulinum toxin was just taking hold, and hyaluronic acid. And I came from a pure socialized medicine background, and I saw this as crossing to the dark side. This was definitely, this was not that it was voodoo medicine, but that it was unnecessary, frivolous, and a waste of money, and
Mm.
uh, and catering to body dysmorphia. And that was a
Mm.
criticism that was the bias that I came to aesthetic medicine with. And I looked at it and dabbled in it, and I soon realized that we are intensely aesthetic beings. Our aesthetic view of ourselves is so tied into our self esteem that you absolutely cannot deny it. So you've got a choice. You can walk around in sackcloth and ashes and let your facial hair grow wild, never have a haircut, don't bother with putting on any clothes. Just shroud yourself in some kind of cloth and walk around barefoot. You can do that. But most human beings absolutely don't do that. Even the good old Neanderthals were carving themselves for aesthetic beautification. It's baked into us as a species. And it's not just us. Look at the animals. Look at the flowers. Which flower gets pollinated? The dull, ugly-looking, wilted one with with poor leaves and no decent petals, or the one that's bright and shining? Which lion gets to procreate? Which birds get to procreate? The ones that are aesthetically beautiful. So it's a hard reality that aesthetics is really part of our evolutionary biology, and to deny it is to actually minimize it. I mean, I had a 90-year-old woman once come to me in my family practice and said, "Dr. Frame, uh, I need some Botox." And I looked at her and I said, "What are you talking about?" She was shriveled and wrinkled. And he said, "No, no, no. I heard that Botox is an antidepressant." And she was absolutely correct. People who get cosmetic treatments find that it improves their mood incredibly. And
Mhm.
you feel better about yourself when you look after yourself. And we do it all the time. We put on nice clothes, we dress up, we have a haircut, we have our hair done, we have our nails done, and it makes us feel better. Yes, you can take it to the extreme. Probably 10% of my cosmetic patients have got body dysmorphia, and they're what we call obsessed, or they have an unreasonable view of themselves. But that's no bigger than the general population. 10% of the world have got body dysmorphia and can't see and over exaggerate their own faults and are obsessed with themselves. So we're not dealing with a much more dysmorphic population, and we're definitely helping them. The number of people, that's what I love about cosmetic medicine, as opposed to family practice that I've loved and served for many years, is I'm used to relieving suffering. In medicine, we relieve suffering. We have people who are sick and in pain and mentally and physically suffering, and we try to relieve it. And we take away some of their suffering. In aesthetic medicine, we have healthy people who are well, and we make them better, and we make them happy. And they say, "Thank you." and they even pay you in the end. And bonus, and you're improving their quality of life. You're making people feel better about themselves. And lastly, there's an artistic component. And which aspect of medicine, except maybe some parts of plastic surgery, can you actually enjoy doing and crafting something that is aesthetically appealing and pleasing and make somebody happy to boot? I can't remember what the second part of your question was. It was why aesthetic medicine is why is it actually real medicine? Well, it's not just makeup. We're not just coating makeup on people's faces. You have to have an incredible knowledge of the facial anatomy. Let's pick the face. You need to know where the muscles are. You need to know how they work. You need to know individual variations. You need to be able to assess an individual and see which of their muscles are moving in which way. Because in med school, we learn what's typical and what's average. But unfortunately, only 30% of us are typical. Most of us are variants. And you have to be able to predict the variants, pick them up, and then accommodate. And most often we're putting needles into people. That's most of aesthetic medicine. We're injecting botulinum toxin, we're injecting dermal fillers. That's the bulk of it. And if you don't know your anatomy and you're not able to predict where the arteries are and where the nerves are, you run into trouble more than other people. And I would say it takes 5 years to get comfortable with the technical side and some of the artistic side of aesthetic medicine, and for your side effect and your adverse event um, risk to go down. They say what 10,000 hours in any field. That's probably equates to about 5 years of practice for most people, and studies have borne this out. They did a study in the States where they looked at dermatologists and their rate of adverse events and side effects. They were obviously high when they first started practice, and they carried on going down slowly. And at about 5 years, they plummeted. So I would suggest that any practitioner that wants to get into aesthetic medicine, make sure you're going to invest a good 5 years of intense practice before you're going to be fully comfortable with aesthetic medicine. You're going to know how to predict adverse and avoid adverse events. And worse, you're going to know how to deal with them when they happen, because this is medicine. Not everything's predictable. And as they say, stuff happens. And, we've over the last, I would say I've had at least 20 patients in the last 23 years that have had serious adverse events, and we've had to rescue them and try and avoid them from getting tissue damage and permanent side effects.
That is a very interesting perspective. I'm personally not as far along in terms of the ethical acceptance, if you will. I still think that it's hard to reconcile what the attitude that we are taught in this socialized system and the very different setting that you work in. Um, but I think that will be something that we will gradually learn to work with. And I know that Saz had a series of questions that he wanted to ask at the end, given that we are nearing the end. Saz, if you could.
Yeah, we just want to say thank you again, Dr. Frame, Gidon, for joining us. Your diversity of experience really brings a lot of weight to the discussion, and it's fascinating to hear just about family practice, the state of the system, and kind of how private medicine, in many ways, is reaching into the new frontiers that may or may not be adopted into their broader system. And we found the conversation on aesthetic medicine fascinating, and there's a whole diversity of thoughts on it. It's an evolving issue or an evolving topic in North America and globally. And we just want to thank you very much and wish you the best in your practice. And as before we see you off, we just had a few rapid fire questions, like one word answer questions that we're going to be asking all of our guests. And so here we go to finish us off. You ready?
Yep, go for it.
All right. Internal or external medicine?
Internal.
Favorite bone?
Nasal.
Most useless physical exam maneuver?
Fundoscopy.
Oh.
No, useless because none of us know how to do it properly.
That's true.
Scrubs or business casual?
Was business casual. Now go for scrubs.
The blank is clearly the coolest organ.
The liver.
No way. It's gotta be done. Okay.
Weirdest place to inject filler?
It's got to be penile.
All right. Well, thank you very much, Gidon, for joining Two Guys in Scrubs, and we wish you all the best.
Excellent. Thank you very much. It's been fun.
Yes. Nice to meet you, by the way.
All right. Thanks. Nice to meet you.
And that was our conversation with Dr. Gidon Frame. Fascinating conversation. Hope you all enjoyed it, and maybe some perspectives that you don't hear directly in our medical school education. It's interesting to hear about the variety of different practice that exists here in BC and more broadly. What do you think, Delbert?
Yeah, and I know for sure that we will be seeing a lot of foreign-trained doctors in the future, given recent policy changes from the government. And I think it's just important and helpful to hear about these different experiences. Just hearing about apartheid is honestly kind of shocking. I don't know about you guys, but thinking back, it really wasn't that long ago. It was within surely our parents' lifetimes, if not our, grandparents. So yeah, having the diversity experiences is really helpful in medicine because we don't, in Canada at least, our patient population is absolutely not homogenous. It's very multicultural. So yeah, it's great.
Couldn't have said it better myself. And why don't you sign us off? I'll give us a jingle. Jingle, 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 jingle.
So that was Two Guys in Scrubs. If you want to support the podcast, please leave us a like or a review wherever you listen to your podcasts. Thanks for listening, and we'll see you next time, aka next year.
See you next year.